shoulder or lip parakeratosis. The lip parakeratosis that you see is seen in a condition called pityriasis rubra pyloris. I don't expect you to remember all this, nor do I remember, because dermatopathology is so extensive. You make your findings and then refer and try to arrive at a diagnosis. So is there alternative hyperkeratosis and parakeratosis? This is again seen in PRP. So this is how you go about. So that's the second layer. The other thing, or is it random, as you see in case of certain dermatitis? There is no specific pattern to it, but you see random areas of parakeratosis. The another important thing that you should see in the parakeratosis is, are you looking at a dry parakeratosis, that is just keratin with some nuclei, or there is some fluid exudation? So the picture on the right, you can see that parakeratosis is there, but it's a wet parakeratin. There is exudation of some fluid. So wet parakeratin usually tells us that it is a dermatitis, eczema or dermatitis. So these are the things. So if you adopt a methodical approach in analyzing the skin slide, we will, with time and practice, will be able to arrive at some diagnosis or differential diagnosis. So the third thing that you look at is, you see the epidermis here. There's a lot of clearing between the epidermal cells. So this presence of cleared space or fluid or edema is called as spongiosis. The spongiosis can be so much so that it can lead to formation of blisters, as you can see in the right slide. So spongiosis. Okay, then you look at the granular layer. So granular layer normally is about 2 to 3 layers thick. You look at the granular layer, is it hypergranulosis or there is hypogranulosis? So that's the next thing that you, so every layer you analyze it. And then you, the other findings are, is exocytosis. Generally, exocytosis is associated with some spongiosis. So you can see that there are inflammatory cells which have come into the epidermis, and the term that is used to describe the presence of inflammatory cells in epidermis is exocytosis. And when it is exocytosis, make a note, what is the kind of cell that you're seeing in the epidermis? Is it lymphocytes? Is it macrophages? Is it eosinophils? Or is it neutrophils? So look at the exocytosis, and again, the type or the nature of the inflammatory cells that is present. Then another finding that you might see is the presence of acantholysis, where you see detachment of the epidermal cells, basically because the intercellular adhesion are destroyed. This is typically seen in pemphigus and related disorders. So when there is acantholysis, you see detached keratinocytes, and the detached cells sort of become rounded. So that's when you identify acantholysis. And then basal cell degeneration. So this is what I showed you. See, basal cell, when you compare the picture on the left, the one on the right, you can see, you can draw a line along the basal layer, which you can see here is disturbed. You can see there is vacuolar degeneration. So that's basal cell degeneration. And other clues to basal cell degeneration is there will be a lot of pigment incontinence when there is basal cell degeneration. And also the necrotic basal cells may form what are called as civet bodies, which are eosinophilic bodies, which may be present within the epidermis or may be dropped into the dermis. So these are the findings that you look for. That is, hyperkeratosis, we learned, is thickening of the stratum corneum. Parakeratosis is presence of nuclei in the stratum corneum. Follicular plugging is, if you see within the follicles, there is a lot of keratin, follicular plugging. Hyper or hypogranulosis. Acanthosis is thickening of the epidermis. So I think I skipped that slide. Okay, acanthosis is thickening of the epidermis. When you have thickening of the epidermis, see whether it is a regular acanthosis, which means the entire lesion has a uniform thickness, or is it irregular in thickness. Spongiosis, exocytosis, acantholysis. Dyskeratosis is presence of prematurely keratinized squamous cells, which I'll be showing in the subsequent slide, and vacuolar degeneration of the basal cells. So basically in the epidermis, you make a note of the presence or absence of these and make a note of the changes that you're seeing in the epidermis. Then if you come to the dermis, you look at the dermis. Dermis, you look for inflammation. Our focus is on inflammatory dermatopathology. So I will not be dealing with other entities. So when you have dermal infiltrate, you see whether it is a superficial perivascular infiltrate, or is it a Lycanoid infiltrate, which means you find a band-like infiltrate at the interface of the epidermis and the dermis, almost hugging and the epidermis with basal cell degeneration. So Lycanoid infiltrate is a band-like subepidermal infiltrate, also called as a interface dermatitis. Or is it a nodular infiltrate like this, or it is a diffuse infiltrate where you find the inflammatory cells teeming between the collagen, so diffuse or interstitial. So these are the observations you should do when you're looking at the inflammation in the dermis. Is it a superficial or deep perivascular infiltrate? Is it a lycanoid? Is it a nodular or a diffuse interstitial? And what is the nature of the infiltrate? What is the predominant cell that is seen? Is it lymphocytes? Is it neutrophils? Is it eosinophils? Or is it granulomas? All these observations, so you make a note of all the epidermal and dermal changes, and Lever has given a very good algorithmic approach to your diagnosis if a particular type of infiltrate is predominant. So that's how to go about it. Now, so approach to your diagnosis is see whether the changes in the skin, is it predominantly in the epidermis or is it predominantly in the dermis? So if there is both epidermal and dermal changes, the epidermal changes takes over. So epidermal changes trumps dermal changes. So if you have a dense Lycanoid infiltrate and the changes Lycanoid reaction pattern in the epidermis, we call it Lycanoid dermatitis. So the epidermal changes takes over when you see both epidermal and dermal changes. So the distribution of the infiltrate, as I told you, the location of the infiltrate, the nature of the infiltrate, and finally clinical correlation. Never ever make a diagnosis of chronic non-specific dermatitis. This is not something that we report in dermatopathology, unlike other inflammation in other organs. We do not call it chronic non-specific dermatitis. It is not to be used in dermatopathology. Now coming to inflammatory dermatosis, the best way to go about it is to recognize the pattern and then try to arrive at a definitive diagnosis. So what are the pattern analysis? So epidermal changes fall into one of these four major patterns, that is psoriasiform pattern, lycanoid or interface pattern, spongiotic, and vesiculobilas. And dermal changes, as I said, could be superficial or deep perivascular. So suppose you have only dermal changes predominating, then it is one of these. And today's topic, I would be mostly dealing with inflammatory dermatosis, where the epidermal changes predominate. So, so coming to the epidermal changes, the pattern analysis, how to go about finding a particular pattern. Now, first thing that you have to do is look at the skin slide under a scanner magnification and to recognize a particular pattern or silhouette. So first identify the particular pattern or silhouette, because 80% of the skin slides are inflammatory dermatosis. So you look at the low power magnification and recognize a particular silhouette or a pattern. So this is how a normal skin, slide, the silhouette of a normal skin. So now what are the different four major reaction patterns that you see in inflammatory dermatosis? First and foremost is what is called as a psoriasiform reaction pattern. Now what is psoriasiform? When do you call it psoriasiform reaction pattern? Is when you find acanthosis, which is regular acanthosis. You can see here the thickening is quite regular. Almost all the retae are reaching the same height. So there is regular acanthosis with elongation of the retae ridges. So this is what is called a psoriasiform hyperplasia or psoriasiform reaction pattern. So thickening of the stratum, thickening of the epidermis with regularly elongated retae ridges is what is called as psoriasiform reaction pattern. Okay. So epidermal hyperplasia with regular elongation of retae ridges. Next we come into the lycanoid reaction pattern. So what is lycanoid reaction pattern? You can appreciate the silhouette here. There is a band-like infiltrate along the basal layer as a result of basal cell degeneration. So degeneration of the basal cell layer and band-like infiltrate is lycanoid reaction pattern. Okay, so this is the second pattern. The third pattern we see is a spongiotic reaction pattern, where we see that epidermis will show presence of spongiosis, that is intercellular edema, with or without blister formation. So that is spongiotic reaction pattern, where there is intercellular edema between the keratinocytes. And the last pattern is Vesiculobulas pattern, where you have a blister or bulla, which may be intraepidermal, as you can see here, or subepidermal. So these are the four main reaction patterns that you get in inflammatory dermatosis. So under the lower magnification, you look at the slide and see if the slide fits into any of these four basic reaction patterns in inflammatory dermatosis. So first thing you need to do is put the slide, see whether you're dealing with the inflammatory pathology or you're dealing with the neoplastic pathology. Now, if it is an inflammatory pathology, are you seeing the changes mostly in the epidermis? That is these patterns that I showed you. If it is mostly in the dermis, then it may be leprosy, or the algorithmic approach is totally different, which I'm not dealing today. So if we are mostly seeing the epidermal changes, and the epidermal changes, look carefully and look at any of these reaction patterns. Now see, when you look at a slide, as I said, you look at the silhouette and see whether I'm looking at a psoriasiform reaction pattern, or I'm looking at a Lycanoid reaction pattern, Spongiotic or Vesiculobulas, just as you look at a bird and you see and try to identify them. Now, say we are looking at this reaction pattern, like a Lycanoid pattern. We saw a bird looking like this. So this is just a silhouette. This bird could be anything from vulture, it could be eagle. So there are so many birds which can look like this if you just look at the pattern. So for example, Lycanoid reaction pattern here, you are seeing something like a Lycanoid reaction pattern, which means we are seeing a band-like infiltrate when we are seeing the basal cell degeneration. Then you look at the textbook and you have a whole lot of conditions which fall under the Lycanoid reaction pattern, prototype being Lichen Planus. So it's practically not possible for us to know all the conditions that fall under the reaction of a particular reaction pattern. The list goes endless, but you have to at least know the most important one and then a few common ones. So I'll be only highlighting a few important under each of these reaction patterns. So it's much like in a crossword puzzle or a puzzle like this. Like there is a reaction pattern, you see this is there, this is not there, or that is there, this is not there. So you note down your points, what are there, and then try to arrive at the diagnosis. So now if you look at, I'll start with Spongiotic reaction pattern. Spongiotic reaction pattern is, we learned, has intercellular edema with or without vesicles. So Spongiotic pattern is classically seen in dermatitis. So that's one of the most common clinical diagnosis that is offered on most of our request forms. So Spongiotic reaction pattern is seen in dermatitis, and dermatitis can evolve from acute to subacute to chronic depending upon the exposure, and the changes that we see in these phases varies. So acute spongiotic, this is the classical picture of acute spongiotic dermatitis, where clinically you see oozing and blister formation. And this is what we see under the microscope. So you can see here, it's an acute reaction pattern. That's why you can see the basket weave is preserved. So for it to become hyperkeratosis, it needs to take some time. So what we see here is predominantly intercellular edema or spongiosis, which have formed large blisters here. So this is the characteristic picture that you see in acute spongiotic dermatitis. So normal basket weave pattern, spongiosis, spongiotic vesicles, and in the dermis you will see papillary dermal edema and the presence of inflammation, which is predominantly eosinophils. So that's the feature of acute spongiotic dermatitis. Now as it progresses, the epidermis starts becoming thicker, the edema becomes less, and it starts showing hyperkeratosis. So you can see here, subacute dermatitis, the epidermis is becoming thick. There is spongiosis, but only occasional vesicles. Remember I told you parakeratin in case of dermatitis is usually wet parakeratin. So this is a very, very important point. When you see oozing or wet parakeratin, it suggests dermatitis. So these are the features. So basically you see hyperkeratosis, wet parakeratin, spongiosis, the epidermis starts becoming thick and acanthosis. Inflammation is again there with eosinophils. Dermal edema subsides. Now, as it progresses further, you see this is chronic spongiotic dermatitis. The spongiosis is minimal here, and the dermis will show fibrosis. So this is something called chronic spongiotic dermatitis almost starts appearing like psoriasiform pattern, if you can see here. So there is overlap between the reaction patterns. So chronic spongiotic dermatitis will is a histological differential diagnosis for psoriasis. So hyperkeratosis, parakeratosis, acanthosis, mild spongiosis, mild or even absent spongiosis. When you see a lot of eosinophils, that's when you should suspect some dermatitis and dermis becomes fibrotic. So that's the progression of dermatitis from acute to subacute to chronic. In acute, spongiosis and blisters are predominant, while as it progresses, the spongiosis regresses, whereas the epidermis appears thickened and edema becomes less. So if you look at the forms, biopsy forms, the dermatologist would give you a lot of diagnosis like atopic dermatitis, allergic contact dermatitis, irritant dermatitis. There may be varied names that they give based on the clinical findings. But for us, for pathologists, they all have the similar picture that I just described. Histologically, we cannot really distinguish atopic dermatitis or a nummular dermatitis or any of these other kinds of dermatitis. So we don't have to break our head for that. What we need to convey is spongiotic dermatitis. Is it acute? Is it chronic? Or is it showing subacute findings? But there are some clues which may see sometimes. So if in a case of spongiotic dermatitis, you see something like a Langerhans cell abscesses. Okay, you have small blisters containing macrophages, which are basically Langerhans cell cluster that points to allergic contact dermatitis. So we may have some clues, but not always. So you may find Langerhans cell microabscesses, which suggests allergic contact. So you may give your impression as spongiotic spongiotic dermatitis, possibility of allergic contact dermatitis. Or if you see a spongiotic dermatitis with a lot of neutrophils, normally you don't see neutrophils, it's usually eosinophils that are seen. But if you see a lot of neutrophils, it suggests an irritant contact dermatitis. So these are some pointers which may give clue to the cause for dermatitis, but not always. So, but if these are there, you may make a mention of that in your comment. Next, coming to, I hope I'm not too fast. Is the speed okay? Is it fine?
Yes, ma'am. Yes.
Yes. Okay. Okay. So next we move on to psoriasiform reaction pattern. Psoriasiform reaction pattern, as we learned, is the epidermis is thickened and it is a regular acanthosis. You see that regular elongation of the rete. So that is psoriasiform reaction pattern. Now, a prototype for psoriasis reaction pattern is Psoriasis vulgaris, where you know there is plaques, scaly plaques that are seen. But not often do they take a biopsy in classical cases, but in some cases where there is a clinical differential diagnosis, a biopsy would be taken. And this is the finding that you see in psoriasis. So you see that epidermal hyperplasia is there. It's a regular acanthosis with regular elongation of the rete ridges, which often get fused to give an elephant leg appearance like this. And you see hyperkeratosis, you see parakeratosis. The parakeratosis here is confluent, you see throughout, and you see things that you need to observe. I said, look at the parakeratin, wet or dry parakeratin. Because for psoriasis, one of the main differential diagnoses is psoriasiform dermatitis. Okay, and dermatitis, you will get wet parakeratin, some spongiosis, some eosinophils. Whereas in psoriasis vulgaris, we see hyperkeratosis with dry parakeratin. You see the granular layer is decreased or almost lost here. There is acanthosis, which is regular elongation of the rete ridges, the suprapapillary thinning. Above the dermal papilla, you see that there is thinning of the epidermis. The papillary dermis will show congested vessels and lymphocytes. So these are the changes that you see in psoriasis vulgaris. Along with that, in the epidermis, you see this collection of neutrophils, neutrophilic abscesses, what are called as the Monroe's abscesses. Less often you see also abscesses within the stratum spinosum, that's called as spongiform pustules of Kogoj. They are very infrequently seen. So these are the changes that are seen in psoriasis. So to summarize, psoriasis has regular acanthosis, regular elongation of the rete, Hyperkeratosis and parakeratosis, decreased granular layer, neutrophil aggregates that form Monroe's abscesses and spongiform pustules of Fogot, suprapapillary thinning of epidermis, and papillary dermis shows dilated vessels and lymphocytic infiltrate. So, is it always required to find Monroe's abscess and or spongiform pustule to make a diagnosis? No. Many a times we just see the other changes of psoriasis and Monroe's may be absent. In spite of that, maybe particularly if it's a partially treated case, you do not find the Monroe's abscesses. But if you see rest of the findings, you can suggest psoriasis and make a mention that the Monroe's abscesses, which are characteristic of psoriasis, are not seen. So what are the psoriasiform reaction pattern? What are the most important histological differentials when you have a biopsy? Because as I said, a classical case of psoriasis vulgaris is usually not biopsied. Only when there is a clinical overlap, they would be biopsied. So what are the conditions that histologically mimic psoriasis vulgaris? Chronic spongiotic dermatitis, as I just showed you, can look very psoriasiform and may be mistaken for psoriasis. So I'll come to how to differentiate. Dermatophytosis, Lichen Simplex chronicus, Pityriasis rubra pilaris. These are 4 entities which can mimic psoriasis vulgaris histologically. Although Lichen Simplex chronicus is not a clinical differential, but these are the histological differentials that we should consider when we have a case of a case looking something like psoriasis. So when do you call it psoriasiform dermatitis? Now, if you see here, it almost looks like a regular acanthosis with elongated ricae. But why is it not psoriasis vulgaris? Because you see here wet parakeratin. You see a lot of spongiosis. You see a lot of eosinophils. Eosinophils are not seen in case of psoriasis vulgaris unless it's a drug-induced psoriasis. So generally, eosinophils are absent. So now this case, we would think more in terms of a psoriasiform dermatitis and not psoriasis vulgaris, because we see wet parakeratin, we see a lot of spongiosis, and we see edema and eosinophils in the dermis. So this is more likely to be a psoriasiform dermatitis than a psoriasis. So spongiosis, wet scale, eosinophils suggest psoriasiform dermatitis rather than psoriasis. It's coming to Lichen Simplex chronicus, another thing which has a very psoriasiform reaction pattern with acanthosis. But how do we differentiate? If you again look at that, you see that there's a prominent granular layer here. We saw that in psoriasis, the granular layer is decreased or almost absent. Other thing you see here is that the elongation is not so regular. The retae are slightly abnormally elongated, and you'll see a lot of fibrosis. So you look at every layer in the epidermis, make a note of it, and then you try to fit your diagnosis looking at the clinical findings. So very thick, compact hyperkeratosis, parakeratosis, but thickened granular layer, vertical fibrosis. So these are the findings that you see in case of Lichen Simplex chronicus. Again, dermatophytosis, you can see here it looks very, very similar to psoriasis, but you can see neutrophilic aggregates here. But if you are seeing something looking like psoriasis with something looking like Monroe's abscess here in the down picture in the stratum corneum, but you see some spongiosis and eosinophils, always do a past stain because it may be because of dermatophytosis. So this is also, whenever you find neutrophils in the stratum corneum with clinical findings similar to dermatitis like edema, eosinophils, spongiosis, do a past stain to rule out dermatophytosis. Next is Pityriasis rubra pilaris. Again, you can see here there's a psoriasiform reaction pattern. You see a lot of hyperkeratosis, parakeratosis. But what are the things which go against the psoriasis here? I'm sorry, at this magnification, you cannot appreciate it well, but this has the alternating hyperkeratosis and parakeratosis that I just described. But at this magnification, again, you can see the granular layer is there and it's quite prominent. You can see the suprapapillary plates are thick rather than thin. So all these are the pointers that it's not a psoriasis vulgaris. So this is how you go about coming to a diagnosis or differential diagnosis in dermatopathology. Every layer is to be meticulously examined and the points noted down to arrive at the diagnosis. Next, coming to the Lycanoid reaction pattern. Now, Lycanoid reaction pattern, as we learned, is interface dermatitis, where you find a band-like or a subepidermal inflammation and basal cell degeneration. Now, I showed you earlier a long list of Lycanoid reaction patterns, but what is important for us to is to at least know a few important ones. The prototype being Lichen Planus. Lichen Planus again has several variants, and then these are the others. So this is a classical Lichen Planus where you see the epidermis. What is striking is the Lycanoid or band-like infiltrate. You see acanthosis, which is not regular acanthosis like you saw in case of psoriasis. It's rather irregular acanthosis. You see hyperkeratosis, and you see the granular layer. We'll come to that in the next slide. So because of the basal cell degeneration, the rete ridges are usually pointed or sawtooth appearance in case of Lichen Planus. Just for you to show a comparison of the normal skin below. So this is a higher magnification. You can see here the granular layer is quite prominent, often wedge-shaped hypergranulosis. And you see there is hyperkeratosis, but there's almost absent parakeratosis. If you see, there is an inverse relationship between a granular layer and hyperkeratosis. In psoriasis, you saw granular layer is not there, but parakeratosis is there. Here, whenever granular layer is there, there is no parakeratin. So there is an inverse relation between them because of the maturation. So you can see here the basal cell degeneration. You can see the basal cell degeneration in some areas quite subtle, but you can see that you cannot draw a clear line that we saw in a normal epidermis. The rete are pointed. So to see from above, there is hyperkeratosis, hypergranulosis, which is wedge-shaped, acanthosis, pointed sawtooth rete ridges, basal cell degeneration, lymphocytic infiltrate, and pigment incontinence. So evidence for basal cell degeneration is pigment incontinence and civet bodies, which are necrotic keratinocytes. The necrotic basal cells will look as pink bodies like this, which may be present in the epidermis or may be dropped into the dermis. So that is pigment incontinence. So this is when you have basal cell degeneration, if it is significant, you might see the basal cell degeneration may be separated from the dermis, creating these small cleft-like spaces, which are called as the Max Joseph spaces. So this is again, you can see here, civet bodies, basal cell degeneration, very irregular appearing basal cells. So to summarize the features of Lichen Planus, it is irregular acanthosis, hyperkeratosis, focal wedge-shaped hypergranulosis, thinning of the rete ridges, vacuolar degeneration of the basal cells, necrotic keratinocytes, which are seen as civet bodies, and band-like infiltrate. Pigment incontinence, again a feature of basal cell degeneration. So now if you see this case here, it almost looks very similar to Lichen Planus. You can see a wedge-shaped hypergranulosis. You can see dense subepidermal infiltrate. Now what is against Lichen Planus here is the presence of eosinophils. In Lichen Planus, you should not find eosinophils, except in a variant of Lichen Planus, which is called as hypertrophic Lichen Planus. So if you find a Lycanoid reaction pattern with lots of eosinophils or predominantly eosinophils, then our diagnosis to be Lycanoid dermatitis rather than Lichen Planus. Because as I said, Lichen Planus eosinophils are discounted only in hypertrophic Lichen Planus. In all other variants, you should not find eosinophils. So if you find eosinophils, it's more likely to be Lycanoid dermatitis. Now this is a slight variant of Lichen Planus, which is called as Lichen natidus, where again you see a band-like nodular infiltrate, but it is restricted to just a few rete ridges. So you can see the dense infiltrate hugging the epidermis with basal cell degeneration, lymphocytes, but it's restricted to just 2 or 3 rete, and the rete surrounding the lesion is often extended around like a claw. So that's a typical finding of Lichen natidus, and you may also in Lichen natidus may find a few histiocytes or giant cells. So this is a variant of Lichen Planus called as Lichen natidus. Next, coming to Lichen simplex at Atrophicas. Now again here on the picture on the left, you can see it looks very similar to Lichen Planus. You have basal cell degeneration. You can appreciate here there's a dense subepidermal infiltrate almost looking like Lichen Planus, But if you see something like lichen planus on a genital skin, then you should consider lichen simplex chronicus, lichen simplex atrophicus or LSEA. And this lesion, this early changes will look very similar to lichen planus, but over the course of time, this lesion will progress to marked hyalinization of the collagen. The infiltrate, which was superficial, starts moving down deeper, and you see the upper dermis will be replaced by uniform homogeneous collagen. So that is lichen simplex, but the early stages, the inflammatory phase of LSEA can look very similar to lichen planus. So if on a genital skin, you should think of lichen simplex et atrophicus. Another condition where you have Lycanoid reaction pattern is Erythema Multiforming, which is usually drug-induced. And what is striking in Erythema Multiforming, along with the Lycanoid features, that is basal cell degeneration and band-like infiltrate, you find the presence of necrotic keratinocytes or dyskeratotic cells. You see along the full thickness, you can see here along the full thickness of the epidermis, you have these necrotic keratinocytes having eosinophilic, brightly eosinophilic cytoplasm and a pycnotic nucleus. And what is striking in case of Erythema Multiforming, the infiltrate is much less compared to the epidermal changes. So very sparse inflammation, which often you see along the basal layer with marked necrotic keratinocytes. This is a feature of Erythema Multiforming. Another entity where you get Lycanoid reaction pattern is discoid lupus erythematosus, where again you see basal cell degeneration, but along with basal cell degeneration and Lycanoid infiltrate, you see marked follicular plugging with keratin. There's a dermal mucin and dense perifollicular inflammation. So it's difficult to remember all these findings, but these are some of the common entities which fall under the Lycanoid reaction pattern. So you can see here almost looking like lichen planus, you see basal cell degeneration, some Lycanoid infiltrate, but the striking dermal mucin, perifollicular infiltrate. So these are the features of discoid lupus erythematosus. So coming to Lycanoid reaction pattern, the most important and the prototype entity in this is lichen planus, which has several entities. As I told you, eosinophils are rare in lichen planus, except in hypertrophic lichen planus. And if you find a Lycanoid reaction pattern with a lot of eosinophils, offer a diagnosis of Lycanoid dermatitis. Parakeratosis is usually absent in lichen planus. As I said, when you have hypergranulosis, there is no parakeratosis, except in oral lichen planus where you can get parakeratosis. Also, if you're finding something looking very similar to lichen planus, and clinically they tell you it's a single lesion or a solitary lesion, it's unlikely to be a lichen planus because lichen planus presents as multiple violaceous papules or plaques. If it's a single lesion looks like LP, think of lichen planus like keratosis. Also, as I said, if you find something looking like lichen planus on a genital skin, we are probably looking at an inflammatory phase of lichen simplex X atrophicus. Coming to the last reaction pattern, that is Vesiculobilas reaction pattern, is presence of blister or vesicles within the epidermis. Now, when you have a bulla within the epidermis, the three important, your algorithmic approach to arriving at a diagnosis in Vesiculobilas reaction pattern should be: number one, assess where is the split. Is it intraepidermal or is it subepidermal? So, is the blister intraepidermal? If it is intraepidermal, where in the epidermis is it? Is it subcorneal, suprabasal, or random? So you look at the level of the split. Or if it is subepidermal. The next thing you look is there some pointers to the mechanism of the blister formation? So if you find acantholysis or detachment of the epidermal cells, then you're probably looking at the pemphigus group of diseases. Or if you see marked intercellular edema with spongiosis, it is because of spongiotic blisters that I showed you earlier. So look at the mechanism. Rarely you might see the presence of multinucleated giant cells, the suggestive of herpes. That's rarely. So herpes could be it. So look at the mechanism. And then lastly, you look at the dominant inflammatory cells that you are seeing. Are we looking at predominantly eosinophils in the blister, or neutrophils or lymphocytes? So if you look at these three main features, then you can arrive at the diagnosis. So Apart from spongiotic blisters, which I showed you, the next main category for blister formation in the skin is autoimmune diseases or immunobullous disorders. So how do we make a diagnosis of these blistering disorders? As I said, look at the blister. Is it intraepidermal or is it subepidermal? If it is intraepidermal, if it is it subcorneal, then it is mostly pemphigus foliaceus. If it is intraepidermal in the suprabasal location, it is Pemphigus Bulgaris. If it is subepidermal, a lot of disorders, bullous pemphigoid, bullous lichen lupus erythematosus, Epidermolysis bullosa acquisita, Dermatitis Herpetiformis, these are some of the entities that result in subepidermal bulla formation. Now, Pemphigus vulgaris, we know that the patients present with widespread flaccid blisters, and the reason for blister formation here is because it's an autoimmune attack on the desmosomes, which are intercellular adhesion molecules. So when that happens, there is widespread acantholysis. So what are the features of Pemphigus vulgaris? You see a blister here, which is intraepidermal and in the suprabasal location, and within the blister cavity, you see these acantholytic cells. So when these cells fall out, they become rounded. So you appreciate the acantholytic cells. So what are the two things you should see? Three things you should see. Number one, the location. So location here is intraepidermal in the suprabasal location. Number two, is there some mechanism? Yes, we can identify acantholytic cells here. The third thing, what are the inflammatory cells that are present here? Even in this magnification, you can appreciate their eosinophils. So this is a classical picture of pemphigus. Even here, you can see some eosinophils in the adjoining areas. So they also give us some clue. So you have an intraepidermal suprabasal bulla containing acantholytic cells with eosinophils. So we are looking at Pemphigus vulgaris. Here again, you can see suprabasal. Sometimes the epidermis extends as villi-like structures like this, which are lined by basal cells. And this gives what is called as a row of tomb appearance in Psoriasis vulgaris. So we see an intraepidermal suprabasal blister containing acantholytic cells with the presence of numerous eosinophils. This is, again, you see a blister here, which appears to be in the subcorneal location. We can identify the mechanism. We see the acantholytic cells, and usually it is cell-prover. Pemphigus foliaceus will rarely show inflammatory cells, but if you see subcorneal blister like this with acantholytic cells, we can offer a diagnosis of Pemphigus foliaceus. The gold standard, however, for immunobullous disorders is immunofluorescence. Irrespective of whether it is Pemphigus vulgaris or foliaceus, it shows this typical chicken wire kind of immunofluorescence because the antibodies are directed against the desmosomes, which are intercellular adhesion. So this fishnet appearance or chicken wire appearance is classical for Pemphigus foliaceus. So coming to subepidermal blistering disorder, where you find blister in the beneath the epidermis. So the most important in this subepidermal blister is bullous pemphigoid. And in this condition, clinically, the patients will have tense blisters because the whole epidermis is above the blister. It has some strength to it. It doesn't break off like a Pemphigus vulgaris. And here the antibody attack is on the hemidesmosomes, which are basically bind the epidermis to the basement membrane. So histologically, we see a subepidermal blister. You can see here, location, it is subepidermal because you see the entire epidermis above. And if you look at within the blister cavity, there are a lot of eosinophils again here. So it's a subepidermal blister containing a lot of eosinophils. Our diagnosis should be bullous pemphigoid. Okay. So what do you see under immunofluorescence here? You will see the presence of the hemidesmosomes are attacked here. So you have the presence of immunoglobulins which tag along the basement membrane. So a linear IgG is suggestive of bullous pemphigoid. Now coming to the third important condition is Dermatitis Herpetiformis, which also leads to subepidermal blisters. And clinically, these present with multiple itchy papillovesicular lesions. And what you see here is early in Dermatitis Herpetiformis, you have the presence of neutrophilic abscesses in the dermis, in the papillary dermis, which cause the split. Okay, you can see here the neutrophilic abscesses in the dermis which cause subepidermal split. So initially you have a multilocular blister like this. Eventually it forms something like a unilocular blister, which you see almost looks like the bullous pemphigoid that we saw. But what is characteristic here is the presence of neutrophils in the blister. So the nature of the infiltrate is very important. So if you have a subepidermal blister with eosinophils, think of bullous pemphigoid. If it's a subepidermal blister with neutrophils, think of Dermatitis herpetiformis. And immunofluorescence will show this classical IgA deposits in the papillary dermis. Another important clue to Dermatitis herpetiformis is it's more useful to look at the adjoining papillae and look for these neutrophilic abscesses. So this is a very important clue to Dermatitis herpetiformis. So many a times the adjoining epidermis gives a lot of clue. Like in Pemphigus, we saw few eosinophils in the adjoining epidermis, because sometimes the blister may be broken, the inflammatory cells may be lost. So the adjoining epidermis gives a lot of clue. Now, another subepidermal blistering disorder is epidermolysis bullosa acquisita. Now, if you look at this here, again we see a subepidermal blister, but it is almost cell poor. You don't see any inflammatory cells here. This is a classical picture of epidermolysis bullosa acquisita, which is a genetic disease where the patients get blisters. It's called mechanobullous because at any site of any trauma, they get these blisters. And histologically, you see subepidermal blister, which is cell poor. Okay. So there is a rare variant of inflammatory EBA with the eosinophils, which can look like BP, with neutrophils, which can look like DH. So those are also there. So that's the reason immunofluorescence is always considered a better diagnostic modality than biopsy alone. So bullous SLE, if you see, again looks very similar to Dermatitis herpetiformis, subepidermal blister with neutrophils. So subepidermal, we saw that intraepidermal blistering disorders is not that confusing. If you have a subcorneal with eosinophils, it is Pemphigus foliaceus. Intraepidermal in the suprabasal is Pemphigus vulgaris. But in subepidermal, we saw a lot of entities. So how do we go about it? So if you look at a subepidermal blistering disorder with little or no inflammation, then we are looking at mostly epidermolysis bullosa acquisita, but do keep in mind that bullous pemphigoid sometimes can be cell poor. If we see predominantly eosinophils, then we are looking at bullous pemphigoid. If it is predominantly neutrophils, it is either Dermatitis herpetiformis, bullous lichen lupus erythematosus, or inflammatory EBA. So this should be how your diagnostic approach to be. So a final diagnosis always taking into consideration the clinical histology and the immunofluorescence. And dermatopathology is always you build your blocks and arrive at a diagnosis by looking at every single point on the slide. As I said, right from the stratum corneum to low down in the subcutis. So note down all the points that you are seeing, look at the clinical diagnosis, correlate and arrive at a diagnosis or differential diagnosis. And if you do not get a definitive diagnosis, always mention the points. As I said, dermatologists have some idea, particularly the ones in academic practice. They understand the pathological terms and they will be able to think of an alternate diagnosis in case we are not able to. So that brings me to the end of the lecture.
Thank you so much, madam. It was such an excellent lecture with such beautiful and valuable points and photo micrographs. Now the forum is open for questions.
Actually, I do have some whole slide images. If I have time, I could show them. Maybe 10 minutes.
Okay, ma'am. You can continue then. We'll have a round of questions as well.
Yeah, maybe after that.
Okay, ma'am. All right.
Let me see. I had some technical issues, so I'm not sure if.
The questions can be typed in the chat box.
Should I open the others and keep so that I don't lose time?
Ma'am, you can share the images.
Yeah, is it visible now?
Yes, ma'am. It is.
Okay. Yeah. So this is an image of which shows here that what we see here is I'm sure all of you can understand this is a psoriasiform reaction pattern. You see regular acanthosis, almost all the retae are extending to the same length. So we have regular acanthosis. We see that there is hyperkeratosis, right? We can see that the granular layer is almost decreased in certain places. So you can see the granular layer is lost here. There is hyperkeratosis, there is parakeratosis. The parakeratin that we see is confluent, it is dry, there is no fluid there. And you see that there is a large macropustule, neutrophilic pustule here. And you see that there is a suprapapillary thinning. Okay, the papillae you see have some edema and there is some perivascular infiltrate. So this is a classical psoriasis vulgaris. So my request to the budding pathologists, the postgraduates is, I see a lot of postgraduates writing epidermal, the changes as section shows stratified squamous epithelium. Please don't say stratified, it is understood. Say epidermis shows, don't write stratified squamous epithelium, section shows stratified squamous epithelium. So my way of describing this particular case would be epidermis shows hyperkeratosis, confluent parakeratosis, neutrophilic pustule in the stratum corneum, regular acanthosis, regular psoriasiform acanthosis, suprapapillary thinning, decreased granular layer, and perivascular infiltrate, consistent with psoriasis vulgaris. So this should be your description should be brief, to the point, and with all the points that you are seeing. So this is a classical psoriasis vulgaris. Let me go to the next slide. Are you able to see? Are you able to see the next slide?
No, ma'am.
Is it see?
Yes, ma'am.
Okay, so this is the second slide here. What you can appreciate is you can see there is a dense subepidermal, almost band-like infiltrate. You see hyperkeratosis. Yeah, you see hyperkeratosis there.
Ma'am, similar slide, last one.
Same only has come?
Yeah.
Oh, sorry. Has it come?
Yes, ma'am.
Okay. Yeah, so what you see here is epidermis shows some acanthosis, but it's an irregular acanthosis. You see hyperkeratosis. Okay, then you can see the basal cell degeneration. You will see that the basal layer is very irregular and you cannot draw a line. That's an indicator that there is basal cell degeneration. You see there is hypergranulosis, which is classically the wedge-shaped hypergranulosis that is described. Marked pigment incontinence again tells you there is basal cell degeneration. So this is the classical lichen planus with predominantly lymphocytes. And you can see here in this section here, again you see there is hyperkeratosis, but there is no parakeratosis. There's granular layer, which is hypergranulosis with wedge-shaped infiltrate. Then you see basal cell degeneration, pointed ridges. You see basal cell degeneration, very irregular appearing basal cells. There's a lymphocyte infiltrate, which is almost hugging the epidermis. And there's a lot of artifact. This doesn't really look like Max Joseph. These are artificial spaces that have formed. So this is lichen planus. Okay, so you can see the basal cell degeneration, very hazy appearing, irregular appearing basal cells, and the lymphocytes almost hugging the epidermis. So that is hyperkeratosis, hypergranulosis, irregular acanthosis, basal cell degeneration, band-like infiltrate, pigment incontinence. So all these suggest lichen planus. Coming to the next one. I would be happy if someone can attempt a diagnosis. Any postgraduate can attempt a diagnosis here. Reaction pattern.
Spongiform.
Yes, it's a spongiform reaction pattern. What you see is epidermis shows mild acanthosis. You see intercellular edema. You see lymphocytic exocytosis. Some small blisters formation here. So this is a spongiotic dermatitis or spongiotic reaction pattern, spongiotic dermatitis. Okay, so that's the third one. Is it seen?
Yes, ma'am.
Okay, so someone can attempt this.
Vesiculobilas.
Vesiculobilas. So how do you approach it?
Subepidermal.
No, it's not subepidermal. See, I think for you it may be. So you can see the basal layer here. You see this is the large blister here. You can see the basal layer forming a tombstone like at the base of the blister. Within the blister cavity, you can see these acantholytic cells. And within the blister, you have eosinophils, but there are a lot of neutrophils also. So this could be a secondary infection that has happened. But you see a large blister in the intraepidermal, suprabasal. You can see the basal layer beneath here. And within the blister cavity, you see a lot of acantholytic cells. You have numerous eosinophils as well as some neutrophils. So you can see here, you can appreciate the split extending here in a suprabasal location. And so this is a Pemphigus vulgaris, probably secondarily infected. Okay, so that's Pemphigus vulgaris. You can see, right? Yeah, so what is this now here? You can see two blisters here. Where is the location of the blister?
Subepidermal.
Yes, this is subepidermal. Although here you can see at the edges, you can see always what happens is when the blister is there for a long period of time, one of the challenges is that edge of the blister, some regeneration starts happening. So you may see, so don't look at areas. You can see here the entire epidermis is above, including the basal layer, right? You can see the entire epidermis, including the basal layer, is above. So this is a subepidermal blister with numerous eosinophils, predominantly eosinophils. So this is, so what would it be? If it is a subepidermal with eosinophils, you can appreciate a lot of eosinophils with the dirty granules. It would be
Bullous pemphigoid.
Bullous pemphigoid.
Bullous pemphigoid. Very good. The last one I have. Okay, here again you can see a blister. Again appears to be nice subepidermal bulla with the entire epidermis on top, and you look at the inflammatory cells, they appear to be predominantly neutrophils and with a few eosinophils, of course. So what is very important sometimes is always dermatitis herpetiformis. The adjoining epidermis gives a lot of clues. So you can see this papillary neutrophilic abscesses. This is very characteristic of dermatitis herpetiformis. So you see this papillary neutrophilic abscesses. So that's again dermatitis herpetiformis. One last case which I didn't discuss that for want of time, but let me just complete. I think exam going PGs can tell me what this entity is. What are you seeing here? Is it what pattern is it? What are you seeing here?
Dilapidated brick wall.
Very good. So this again you are seeing blisters here with lot of acantholysis, but the acantholysis is not complete in the sense there are still some attached to each other, giving a dilapidated brick wall appearance. So this is a differential for Pemphigus vulgaris because of the presence of acantholytic cells. And what is this entity? Haley disease. Yes. So yeah, that brings me to the end of the talk. Inflammatory dermatosis is a very, very vast topic. I've just tried to highlight the most important points and the most common entities. So my request to you is to adopt a very methodical approach, looking at every finding in the epidermis and dermis, and don't try to fit your findings into the clinical diagnosis. Thank you very much.
Thank you, madam, for putting in your precious time again for these images. The forum is open for questions now. You can type in your questions in the chat box. I request everyone to kindly fill the feedback form as well. The feedback form is sent to your mail ID as well. I request Dr. Divya to deliver the vote of thanks.
Thank you, Dr. Shubha. It gives me an immense pleasure to deliver the vote of thanks for this online event of a guest lecture today. I would like to thank our beloved guest of honor, Dr. Kanthalata Pai, Professor of Pathology, for having delivered such a wonderful, articulate lecture on dermatopathology. I'm sure all of us face difficulties and doubts when it comes to dermatopathology slide, especially the inflammatory dermatopathology. Thank you very much, madam, for explaining it beautifully with the pattern-based approach. and also highlighting that how it is very important to have a clinical correlation, and also highlighting that how important it is to have an unbiased look at the slides first, and then look at the clinical diagnosis or the differential diagnosis provided. It wasn't. It was useful not only for the postgraduates today, and also the practicing pathologists. And also thank you for sharing the whole scanned images of the good cases, the classical cases. I'm very sure all of our postgraduates would be benefited with it. We look forward to having you again, madam. I would take an opportunity to thank our Chancellor, Yanapoya Abdullah Kuni, Pro-Chancellor Mohammed Farad, beloved Vice Chancellor Professor Vijay Kumar, Registrar Dr. Gangadhar Somayaji, and our beloved Dean, Dr. Musapa, for the continuous support and encouragement in all our endeavors. A special thank to our head of the department, Dr. Prema Saldana, and all the faculty members, postgraduates, non-teaching staff, for the entire team, for the without whom it wouldn't be a successful webinar today. A special thanks to the IT department for the smooth run of the webinar, and also to all the participants, including the dermatologists, pathologists, postgraduates of dermatology and pathology, for active participation. We had a good participation, almost around 200 participants, both in the Google Meet as well as the YouTube. Thank you very much, everybody.
Thank you very much once again for the opportunity.
Thank you, madam.
Yeah.
Thank you for joining us, and we look forward to see you again with more interesting and upcoming lectures. I thank each and every one of you all to making this event complete and grand, and we'll come back with more interesting lectures in this series of guest lectures. Thank you so much, and it's a kind reminder to fill in the feedback form through your mail ID and your chat box. Thank you.